If you've been anywhere near a television, near a phone, and you've been scrolling, you've seen that there is a there are a slew of medications. They're out there to treat various diseases, various conditions. And it seems like more and more and more are coming out every day. And this is no exception when it comes to diabetes. In fact, it seems like the diabetes world is exploding. Right now, we're concentrating on a particular type of medication, but it is huge and it is a big, big, big money maker for the pharmaceutical industry. And so often in my office, I hear people talking about medications and the fact that they believe that there is this conspiracy, if you will, to have people on medication. And we're not getting into conspiracy theories, but we want to spend some time talking about how we go about choosing medication. How do I, when you walk into my office, how do I decide what medications to put you on for your diabetes? That's what we're spending our time doing right here, right now. So if you've been wondering, why am I on that medication? What is it really doing for me? And how did they decide to do that? This is your episode right here, right now. Hey, I'm Dr. Dwain Woode. If you're new to me, that's Woode with an E. The E stands for endocrinology. Here I educate, I empower, and I encourage you to take charge of your health and your life. Avoid complications, go to the next level. We're creating the life we've always wanted, and we are living that amazing limitless life. You don't need superhuman strength. What you need is a strategy you can trust, a plan you can follow, and the support to show up every single time. That's why we're here. So you can be here for those people and for those events that are so important in your life. If you're new, go ahead and drop new in the comments because I want to give you a hand clap and some music. And let you know that I am so excited that you are here with us, whatever platform that you're on right now, whatever city, state, country that you're in, I'm glad that you are here in this space. And a special shout out to our accelerator members. Thank you for coming through. And a special shout out to two groups of people that are so important to us that have been watching. First of all, the folks from Atlanta, Berean. We're so glad that you are here, the church there in Atlanta. Thank you for coming through. If you're from Atlanta, Berean, go ahead and drop Atlanta in, drop Berean in the comments. Drop Berean so we know you're here. And then from Louisville, Kentucky, the Magazine Street Church there. We are so excited that you are joining us as well. So if you're from Magazine Street, just put magazine. So if you're from Berean, put Berean. If you're from Magazine, put magazine. And then for everyone else, I want you, if you are ready to jump into what we're talking about tonight, just put ready. Just put ready right there, okay? And so as we go through the episode tonight, make sure that you are jumping in. If you know somebody that needs to be here, tell them to go ahead and come on because we are having a great time. So before we get into all of that, though, let's hop over and let's take a look at what's been going on with blood sugars. And first, we're going to take a look at my Freestyle Libre, which is what you see coming up on the screen. This is my Freestyle Libre, and there is my blood sugar right about there, right? So 85 is what my blood sugar is right now. And down below, right about here, is what my trend is for the last 12 hours. Okay, so that gives you a trend for the last 12 hours right here, what my blood sugar is right now. And I love to look at the reports that are in here, particularly the 90-day ones, because this tells me what my average blood sugar should be. Now, I'll tell you, I did get blood work, and let's do one thing here. Let's go back here. I did get some blood work last week, or when did I say? Last week before. So I got an A1C in the office from one of our machines, and then I got blood work that's off. And the blood work was not what I was expecting. So we'll be sharing that with you guys coming up in a show soon, right? So we can go through that. So 90 days right there, and 96% in target. And then Here's my average glucose for 90 days, right? So this is what I expected when I got my blood work, but yeah, we'll see. So 101 is what my average is over the last 90 days. And then down here, I love this graph or this group of graphs because it allows me to see what my blood sugars are over the course of the day. And then I can make decisions about what to do based on what those numbers are. Now, this is an amazing process, right? So this is the crux of what we need as we're making decisions about what to do in our lives on a daily basis. And one last thing that I want to do here is looking at my glucose management indicator for 90 days. So this thing is saying that my glucose or my A1C should be, and this is a surrogate, 5.7, right? 5.7 over 90 days. And then let's go ahead and let's get over to my Dexcom Clarity, not Clarity, but my Dexcom G7. And right now, blood sugar of 96. This is what it has been for the last 12 hours. And here on this one, if I go to my trends, here's my summary for 90 days. It's saying that I'm in range 96% of the time. My average blood sugar should be 124. Okay, 124, and my glucose management indicator is a 6.3. So when I got my blood work, I was expecting that it would be a 6.3. And you can get a hint from my verbiage that it was not there. So pay attention. We're going to be doing that show coming up soon. And then let's go ahead and we're going to hop over here and I'm going to take a look at my blood sugar, and here's my Keto Mojo. Once again, I don't have the contour strips, which is from this one, so we'll be able to see what the Keto Mojo is. Here is my glucose strip, and here are my ketone strip, and then I need a lancet. So let's go ahead and let's do that right now. I'm going to let's go to this view. And I don't see my camera. I don't see my, let's see, where are we? I need to see C. There you go. Okay. So let's go ahead and let's take a look. And this is, and I don't use a lancing device. I just use a lancet. So I'm going to grab this. And let me change this view so you can see. There we go. And just pop that open. And of course, I forgot to get the strip done. And so these are very important. And I love doing this because often I get, turn it around the other way. Often I get questions from patients and from people who just stop me about the differences that they see in glucose meters. And so this is a great opportunity to get you to see what those numbers are. In fact, when I did blood work the other day, I got my glucose from a finger stick. I got, of course, what was on the lab. And then I was able to take a screenshot of both the Dexcom and the Libre at the time when I got blood work. So right now, 99 is what this says my blood sugar is. On the screen, you'll see this says 96. And then if I go over to my Libre, so you guys can't see the whole thing. Let me change my view. Let's go to this one. There we go. Okay, and on the screen you see it says 86. So 99 for the Keto Mojo, 83 for the Contour and the Libre, and then 96. So not far off, but there is a difference there. And then let's go ahead and let's take a look at ketones. And let's do this so that I don't have to stick myself again. And pop this in here. Okay. And what do you think my ketones are going to be? Go ahead and drop that in the comments. And I see someone already guessing there. I think Steve, is that you out there, Steve, saying 3, 2, 1, and it is 0.1. 0.1. So remember, ketones that are less than 0.5 are considered normal. 0.5 to 1.5 considered nutritional ketosis, and then above 1.5 considered therapeutic ketosis. And so let's go ahead, and I do see some of our community members out there, so let's go ahead and say hello. And I see Jennifer. So Jennifer popped in first. Hey, Jennifer said, howdy all. What is going on? Jennifer, thank you for coming through. Cornelia says, ready. And hello, everyone. Hey, Cornelia, thank you for being here. Steve said, hello, friends. And yes, Steve was guessing at 0.2 were the ketones. And as you saw, they were actually 0.1. And then Steve says, I have a problem when I change sensors. My glucose level goes up for 4 or 5 days. Then it levels off. For 4 or 5 days when you change. That's interesting. And Steve, it'd be interesting to see if, let me say it a little differently. It'll be interesting to see what your A1C corresponds to. Either does it correspond more with the higher numbers that you're seeing during those 4 or 5 days, or with the lower numbers that you see normally. Okay, so that'd be an interesting thing to see. One of the things that happens, and over the course of time, we have more and more of these glucose monitors, continuous monitors that are available on the market. And when they first came out, you used to calibrate them, and now you're not calibrating. And so there's some question that people have as to whether we do need to go back to calibration. I don't think we need to, because we're looking for trends so Steve's saying that the numbers correspond to the lower numbers that he was seeing. So good. All right. Well, I like that. And I'm not sure what would cause them to go higher during those first few days. Okay. Interesting. All right. So over the course of the last several weeks, we've been kind of walking through some interesting scenarios, and tonight is no exception to that. So let's just jump right into it and get into our case conference. So let's do that right now. All right, so last time we were here, we kind of introduced an interesting concept that I want to talk about again. And so that's the concept of this house that's on fire. And the reason I want you to kind of think about that is I've actually been using that often over the last several weeks, talking to different people about blood sugars and about what's going on in their lives. And let me make one change here, just a second. About what's going on in their lives, and kind of spending time talking about the idea that, let me explain it a little differently. Let me say this. If your house is on fire and the fire department comes, you understand that there's going to be some damage that's done by the treatment that they are prescribing. And the treatment is, we're putting water on your house. I want that to sink in. The water that's going on the house is going to cause damage. It's going to soak everything. The walls are going to be wet. The furniture may need to be replaced. The paint is going to be messed up. That is what's going to happen. But you know what? If I'm standing outside the house and the fire department comes and they say, hey, do you want water on the house, or do you want not to put water on the house? Guess what I'm telling them? Put as much water as you need to get the house out of fire, or stop the fire from burning. And the reason I tell that is one of the things I comment to patients about in the office is my goal for every single patient that walks through my office, and we're talking about diabetes now, right? So there are other endocrine illnesses that I take care of. I'm talking specifically for patients who are dealing with diabetes. My goal for my type 2 diabetic patients is not for them to be on medication. That's where we're heading. That's the eventuality. That is that's the hope. That's the push. That's where we're going. So anytime someone walks into the office and they walk out with medication, it is not because that is what the ultimate plan is. It is because our goal is to put the fire out. I want that to sink in. I keep saying that. I want it to sink in. The goal is to stop damage. Because if you have not understood yet, it is the high blood sugar that causes the specific damage that comes from diabetes. There's damage to the eyes and to the kidneys and to nerves and to really every single cell in your body. And it is a cumulative effect, meaning that the longer and the higher those blood sugars are, the more damage is being done. And I was talking to someone just today in the office, and I was pointing out to them that one of the problems with diabetes is that initially diabetes is silent. It's not like when you walk down the stairs and you fall and you injure yourself, there is immediate pain. And what do you do when there's immediate pain? You go to the doctor. And you figure out what's causing the pain, and you want the pain to go away. Diabetes initially does not cause pain. And so for years and years and years and years, people are there and they are experiencing the damage, but it is silent. Until one day, it shows up. And people say, well, how did that happen? It just happened all of a sudden. No, it did not. It didn't happen all of a sudden. It showed up when the damage had gotten severe enough that now the body can no longer handle whatever it is. And so now we have damage to the eyes because it's been going all the time. We have damage to the kidneys because there's been constant low-grade damage being done, and it got so much that it shows up. There's been damage happening to the feet and the nerves and the blood vessels. And we show up with neuropathy. We show up with heart disease. But it's not new. It's been happening the entire time. And so the goal is, how do we stop that from happening? I cannot emphasize that enough. The goal is to stop the damage. If we could stop the damage without medication, then great. In fact, I tell folks in the office that, if you go away from the office and you come and you say, you know what, doc, I'm going to go ballroom dancing. I'm going to go line dancing, square dancing. I'm going to go do cartwheels. And you come back and the numbers have been fixed because you cartwheeled and you salsa danced and you square danced and you line danced and you whatever it is, I am elated. But until you line dance and you square dance and you salsa dance and you do cartwheels and the numbers improve, you got to do something to stop the damage. All right? I hope that makes sense to everyone. So let's go ahead and let's talk a little bit. And so we introduced we introduced a patient last time, and so we're going to talk about that patient again, right? And so we're talking now about how physicians choose diabetes medication, right? So how do we choose diabetes medication? So here's our patient, if you remember. There's a 56-year-old male, has type 2 diabetes, and he's been diabetic for 7 years. He's 33. BMI is 33, so he's 232 pounds. And so as you're thinking about this idea of BMI is just another surrogate for weight, right? It helps us to evaluate a few things that the weight itself doesn't really give us. And so if you're thinking about BMI, the way you calculate your ideal body weight, it's 100. And let me come back over here so you can see me. So there's 100 pounds for the first 5 feet. And then for women, it's five pounds per inch beyond the first 5 feet. And for men, it's 6 inches. So for example, a man that's 5 foot 6 inches, then it's 100 pounds plus 6 times 6 is 36, 136 pounds. For a woman of the same height, 5'6", it's 100 pounds plus 5 times 6 is 30, so 130. Does that make sense? Okay, so that's how you calculate ideal body weight. Now for the BMI, if a person wants to change the BMI, they want to go from, a BMI of 36 down to a BMI of 35, then for women, they have to lose 5 pounds, and for men, they have to lose 6 pounds to make that change. Okay, so all right, so this patient is 33 pounds, 33 BMI, is weight 232. He's a truck driver. He's walking, 20 minutes a day, and that's new for him. A1C was 9.1. His fasting glucose 215, creatinine is 1.1, and you see that there. His GFR is 78, and microalbumin is 42. And so those are the parameters that we have for this guy. So looking at vitals, 142 over 88 is the blood pressure, heart rate of 78, weight, we talked about 232, and BMI is 33. Medications that he's on, metformin, atorvastatin, which is a cholesterol medicine, and there's other things, right? Rosuvastatin and simvastatin, and you can go to anyway, a bunch of them. And then lisinopril, you may hear other medications like that. By the way, let's go back to the statin. So statin, anytime you see a statin, right, they tend to end in statin. Rosuvastatin, atorvastatin, simvastatin, that's a cholesterol medicine. And the prils, lisinopril, quinapril, right, so all of those prils, those are ACE inhibitors. And they're given to diabetics specifically because it is a way of protecting kidneys. And of course, this guy is on some aspirin. And there's a whole conversation we can have about aspirin. We won't do that right now. So symptoms-wise, he's having some fatigue, which makes sense. Polyuria, so he's peeing a lot. Polydipsia, he's drinking a lot. Polyphagia, he's hungry. He's got blurry vision, and he's slow to heal. So remember, diabetes makes it difficult, makes it harder to heal. So you get a cut, and normally it heals within a week. When you have diabetes, that cut now takes, several weeks to heal. And that's part of the disease process. We'll have to come back and do another show where we talk about why that is, right? Because there's a specific reason why that happens. So how do we evaluate every patient? Number one, and these are the pillars that we talk about. So we define the problem, we interpret the physiology, and then we decide what we're going to be doing next. Okay, so define the problem, interpret physiology, and then now what do we do? What do we do going forward? And that's important because it is the pinnacle. It is the crux of how we evaluate patients when we see them, right? So what is their problem? What's causing it? And then what do we do? Then what do we do next for that particular patient? Okay. And so there are three pathways that glucose has when it comes into the body. Three main, right? There are a couple of other things which we're not going to get into. But when you think about glucose, blood sugar, where does it come from? Either we're taking it in, food, drinking, whatever that is, or it's being produced in the body. And here I'm including every single mechanism that is in the body that produces glucose, whether that is the liver that's doing it, or the muscles that's not using it, or the kidneys that's reabsorbing it, or there's stress that's happening, you're not sleeping, whatever is causing it, that goes into that middle bucket. And then glucose is used up. And in the used up portion, I'm adding in another concept. It is being excreted. So used up or excreted, because there is a class of medications that we're talking about here in just a minute that specifically targets excreting. So if you could have blood sugars that were 300, 400, 500 and not cause damage, nobody would care. The reason we care is because we cannot prevent damage if the blood sugars stay high. And I want you to remember that. If you could walk around with blood sugars that were in the stratosphere and it was not causing damage, nobody would care because you're not getting any damage. The thing is, we don't know which person is getting damage, which is why we do a lot of screening and evaluations and so forth. Okay, so that's the crux. So let's talk about the lenses that we use when we are looking at patients now, and we're looking to see, okay, how do we go about looking at their medication? Okay, so we're going to talk about how high is the A1C. How high is the A1C? So when you are looking at blood sugars, most medications, and we're talking about medications tonight, so let's go ahead and just put it out there. So most medications will lower blood sugar anywhere from 0.5 in terms of A1C, and we're talking A1C now, anywhere from 0.5 to about 1.6 A1C points. I want you to process that. And if we want to be generous, let's make it 2. So it goes from 0.5 to 2. Which almost no medication does that except insulin, by the way. So we'll talk about insulin another time. So that if someone walks into the office and their A1C is 10, and we say we want that A1C to go below 7, let's just make it 6.9, and it's 10. We're going from 10 down to 9. Down to 8, down to 7. And if most medications will lower your A1C by 0.5 point to 1.5 points, you see immediately that you walking in with an A1C of 10 and me saying, hey, I'm going to put you on one medication doesn't do the job. It's a math problem, y'all. It's not mystical. If you go to the grocery store and the thing you're getting costs $100 and you only have $90, guess what? You can't get the thing. Because they don't match. So if we're trying to lower the A1C by a certain number, then we've got to be able to have the math match. Number 2, what comorbidities do they have? In other words, what other things are going on in them? Most diabetics, when they walk in, they already have high blood pressure in addition to the diabetes. They're already overweight. Some of them have had coronary artery disease. Some of them have strokes and heart attacks. Some may have some kidney damage, which may not be fully evident. So what else is going on in their body? When I write my note, one of the things that I write, there's a sentence there that says, complicated by obesity, heart attack, stroke, kidney disease, right? So there's this whole list of things. And in that line, that tells me and tells the physician what else is going on with this patient. And then what are the side effects? If someone is already predisposed to, say, I don't know, hypoglycemia, or predisposed to dehydration, or they already have some other GI issue, then when I'm looking at the medications that I am thinking about putting them on, I want to be able to assess, will this medication exacerbate the thing that they already have going on? Then number 4, what does the patient prefer? And right here, I'm going to pause. So let's have a conversation. Let's talk about this. What does the patient prefer? What does the patient prefer? That means that in the conversation, we're saying, okay, there's this group of medications that we want to use. And in that group, what does the person who's going to be doing this want to do? Make sense so far? Awesome. I love it. So let's get out of diabetes for a minute and let's talk about the rest of your life. Make sense? Okay. So at your house, a wall has a hole in it. And you go out and you find somebody who fixes holes in walls. And the person comes and says, hey, Mrs. Jones, hey, Mr. Jones, this wall right here that has a hole in it, the best thing to fix that hole is X, Y, and Z. And if we do X, it'll fix the hole, but tomorrow the hole will come back. And if we took Y, it'll last for a couple months and the hole's gonna come back. But if we do Z, then once we patch that hole, then we're good. I doubt that many of us would say, you know what? Let's go with X. Yeah, let's do that. And when the hole comes back, then we move up to Y. And if it comes back again, then we'll do Z. You know what we're going to do? Most of us would say, let's go to Z. So the preference is great. But understand that this is not, oh, let me have my preference, and that's going to fix the problem permanently. So I want you to understand the process. Yes, you can stick your hand in the bag and you can pull out multiple things. But what is going to do the job that we want? I have a lot of folks who come to see us, and during the process of the visit, you know, we say whatever the plan is that we come up with, you know, hey, your A1C is 11. And usually the people who come to see me are not the people who have A1Cs of 6, by the way, right? Because I'm an endocrinologist. And by virtue of being an endocrinologist, the people that I get referred to me are the people whose A1Cs are 10, 11, 12, 13, 14. And so they walk through the door, and if you're at a 14 and I've got to get you down to a 7, let's say that's what we're shooting for. By the way, we're shooting for below 7. So I got to get you down to a 7. We're talking about going from a 14 down to a 13 down to a 12 down to an 11 down to a 10 down to a 9 down to an 8, and an 8 down to a 7. So we're talking about 5, 6, 7, 8. We're talking about 8 A1C points. So that's not a simple feat to do. So there is a preference, but there is reality. So this is what's going through my head. And I dare say, I'm not going to speak for your physician, but I dare say that sometimes that's what's also going through your physician's head. All right. So what is the patient's preference? And what's the long-term goal? What is the long-term goal for this patient? If the goal is, hey, no, we're going to drop the blood sugars today, and it's okay if it goes back up tomorrow because we really don't care, then there are some things we can do. But if we're talking about long life, and remember, long, healthy life, then there are some things that are going to have to happen that may not be totally in your preference. Make sense? All right. So I know we spent a bunch of time on that. So how high is the A1C? And then we kind of walk through this, less than 7, some things that we can do, 7 to 8.9, 9 to 10, and so on and so forth. But remember that the height of the A1C dictates the treatment. Coming in with an A1C of 14 gets a different treatment than coming in with an A1C of 7.1. Let's just make it right above what's considered controlled. So remember, control is less than 7. So if your A1C is 7, right, you're almost there. But if your A1C is 14, you're not anywhere near there. So there's a difference that we've got to do. Something different that we got to do for those patients. Okay, so comorbidities, we've talked about those, heart failure, cardiovascular disease, chronic kidney disease, obesity. And that's a big one because that's the big thing that everybody's talking about now, okay? So when we're talking about medication, what we're doing is we're saying, okay, what is going on currently, and then what are some of the comorbidities with this patient, and we begin to choose a medication that fits within that profile. Okay? All right. So the other thing that we've got to look at is the safety of medications. Metformin is the one that everybody talks about. And metformin has been on the market. It's been in the news. And you guys have heard and seen a lot of the side effects and all the things that come along with metformin, right? I'm going to say to you, there's not a single medication that you can ever take. There's not a single medication that you can ever take that doesn't have a side effect. All medications have side effects. And when we're looking at medications, we are not saying medications don't have side effects. What we're saying is we're always weighing, is the side effect of the medication worse than the disease that we're treating? For example, you get an infection, and we are treating the infection with medication. But the medication caused you to be nauseated. Right? Upset stomach. And so the question that I've got to ask is it worth having you feel nauseated so that I can kill the bacteria in your body before the bacteria causes morbidity and mortality in you? And in most cases, the answer is yes. I'd much rather you be nauseated than for the bacteria to take hold and you become septic and have other complications. So there's every single time that you are being prescribed the medication, the conversation in your physician's head is the benefit of the medication better than the detriment of no medication? Right? Okay, I know the medication has these 5 side effects, but I'm willing to do that. I'm willing to have those so that we can do this thing over here. Right? So that we can have that treatment. So side effects. So metformin, the GLP-1 receptor agonists are also great medications that people are using right now. They cause nausea, they cause vomiting, they can cause pancreatitis in certain people. All right, so what's the benefit? The DPP-4 inhibitors. Sulfonylureas are prone to cause hypoglycemia, so low blood sugar. We got the TZDs can cause swelling. And of course, insulin, right, can cause hypoglycemia. So we're always looking at the risk-benefit ratio. Don't let anybody confuse you that that is not a conversation that happens. It is happening. It may not be verbalized. And sometimes it actually may not even be conscious. But it is happening. And then patient factors and preferences, right? So routes of administration. There are some people who don't like injections. There's some people who can't take big pills. They want liquid. There's some people who, there are all these different types of preferences that patients have for different reasons. And some of them very, very much make sense. Okay, so we're not negating any of that. Occupation and lifestyle. There are some people that I talk to and they say, "Hey doc, based on what I do, I'm always crawling under, a house or whatever." There's certain things that we don't do. Or people who are off for long periods of time. They're in certain environments. There's certain medications that we don't use in those patients because their lifestyle doesn't permit that to happen. Right? Cost is another one. And access. It doesn't matter if I have the best medication on the market. It doesn't matter whether I have the premier stuff. If you can't get it, then it doesn't matter. And that's a whole nother conversation when it comes to coverage and insurance, right? Because as you guys know, that's a big deal. Right now, there's a whole conversation that's happening somewhere in some room somewhere about the GLP-1 receptor agonists because they have become such a mainstay in the management of weight, and yet they are inaccessible to some of our patients. And then the life stages, so what's going on in a patient, and here's another risk-benefit ratio, right? So if I have a patient, let me go back over here. So if I have a patient who is prone to hypoglycemia, I will put them on a medication that does not cause hypoglycemia, understanding that their blood sugars may be higher than I want, but the risk of them having a hypoglycemic episode is not worth me putting them on a medication that drives them there. And so I make a decision that I'd much rather have this patient with a higher A1C, which I don't want, than to have a patient where I put them on a medication, the A1C is now low, but their blood sugars are dropping and they're having hypoglycemic episodes, and that's causing more damage. Do you see the balance? So it's not that. And here's an interesting one, right? People say to me, "Well, if we know that an A1C above 7 is causing damage, why would you then say it's okay that you're 7.2?" Well, it's okay that you're 7.2 because I know if I try to drive it lower, the complications, low blood sugars, hypoglycemia, all the things that come along with that is worse than me saying you got an A1C of 7.2. So are there patients where we allow the A1C to be higher? Yes. Is it causing damage? Yes. But right? Risk and benefit. Risk and benefit. Okay. Does that make sense? I hope that's making sense. And then we want to look at the goals, right? So we want to reduce the A1C to target. Blood sugar, put the fire out. We want to manage weight. That's a big one. We'll have to talk more about that. We want to prevent cardiovascular events. So we don't want you to have a heart attack. We want to prevent hypoglycemia, and we keep talking about it. And the reason I keep talking about hypoglycemia is that's one of the biggest complications of any treatment of diabetes. Right? We want to protect the kidneys, and we want to protect the liver. Right? So we're talking about metabolic associated steatohepatitis, and so they've renamed that. That used to be called NASH, non-alcoholic steatohepatitis. So when we're walking through this process, let's kind of walk through this. So what are we deciding? So new and uncontrolled patient, right? A1C 9.1, like our patient in our scenario. So new or uncontrolled. What's the A1C? Is the A1C high enough that I think I need to do a particular thing, right? So whatever that is. Right? Do they have comorbidities? What do their labs show? Because I'm getting labs. And so what we're looking at is what's going on. How do I assess this patient at this time so that I can do what needs to be done to keep them healthy? Are they on metformin already? And usually metformin is the medication that most people start on, by the way. And so we're not talking about the virtue of metformin versus no metformin. We're talking about the process. Does the patient have cardiovascular disease? Do they have heart failure? Do they have chronic kidney disease? If they do, then there are certain medications I'm going to lean towards, because there are certain medications within the diabetes armamentarium that will help with that. And so then I match the medication to that patient's profile. 9.1, they're obese, overweight, they have a history of coronary artery disease, they have had a stroke, they prefer, right? So I'm putting all of this together in a profile, and I'm coming up now with a medication regimen that fits that. So if they're overweight, I'm more likely to add a GLP-1 receptor agonist. If they have kidney disease or heart disease, I'm more likely to add an SGLT2 inhibitor. If their blood sugar is significantly high, I'm likely to add insulin. If they're older and are prone to hypoglycemia, I probably will stay away from the sulfonylureas, because those medications will cause higher numbers. Okay. So once again, it is a risk benefit ratio. It is not a, hey, I want everybody on that medication. It is okay, what's the best treatment for this patient? Okay. All right. So whenever I see a patient, and you'll see kind of a timeline at the bottom. And so in our office, we see a new patient, we get blood work, we put them on a monitor, one of these continuous glucose monitors that you see me using. We get labs, because we're looking at kidneys and liver and thyroid and cholesterol, all the things that we need to screen for. We send them to diabetes education, and I see them back usually 2 to 3 weeks. And adjust medication. So number one, we get labs because I need to know what's going on in their body. Because we get an A1C in the office, but I need to know what else is happening. We put a continuous glucose monitor on because I want to know on a continual basis, and I want them to be able to see what's going on with their blood sugar. I send them to education. Every new person that walks into the office, regardless of how long they've been diabetic, goes to education. Why? Because I need to make sure that they have a particular fund of knowledge. It's kind of like going to a new job. It doesn't matter how long you've been doing your job. When you show up on that new job site, guess what they do? They do an orientation. You could have been doing your job for 20 years. If you change companies, when you get over there, you're going through orientation. Because we want to make sure that you are using the same language as the new space. So here we are, education. And then we adjust medication based on what we just talked about. The patient profile, how high the A1C is, what their preference is, what comorbidities they have, what side effect profile the medication may have. And so we're adjusting based on all of that. Okay. And I guess one of the points to make is, why do we see them back so soon? Because I've never, ever, ever gone to a coach or taking my son to piano or taking him to a basketball camp and have them teach him something and say, come back in 3 months. You know what happens in 3 months? All the stuff that you should have learned goes away. And so if we're going to be successful, then we've got to have close follow-up, okay? So you see that there. And then escalate therapy. So one of the interesting conversations that I have with patients that are walking through or coming into the office is, how quickly do we want to get this A1C down? Because they'll say to me, well, or they go to their doctor and the A1C was 14. Say that was, I don't know, 3 months ago, 4 months ago. And they'll come to us and now the A1C is not 14, it's 12. And I'll say, hey, we need to intensify therapy. And I get the comment, well, it's improving. So why do we need to intensify therapy? It's improving, but the house is still on fire, y'all. So we're standing outside and we're looking at the building. We're like, look at that. It doesn't seem to be burning as bright. But it's still burning. It's still on fire. Let's put the fire out. Okay? So escalating therapy. Very, very important as we move to talk about how do we keep you healthy? Remember the goal. The goal is always long, healthy life. So how do we intensify therapy? Always, always, always starting with lifestyle. But always starting with lifestyle. What does that mean? That means that the health action plan that we've talked about. So are we walking? Are we doing some strength training? Are we watching our meals, balanced bites? Are we getting good rest? Are we drinking water? Do we have a regimen that is conducive for success? Do I have something that I do to relax? Do I have a centering activity? All of those things, that's lifestyle. Because remember, when cortisol is chronically, tonically elevated, will cause blood sugars to go up. And then we begin looking at medications. We add a second agent, then we add a third agent. We do dual therapy. We do, right? So we're walking through a process. But once again, remember, if your A1C is 14, there is... Can I say that? Yeah, I think I'm going to say that. So if your A1C is 14, and we want to get the blood sugar down like now, there is no way. And now we're talking about orals. We're not even including insulin in this. There's no way to get that down with one medication. And we're not saying that one medication over the next year can't get your blood sugar down. It probably could. But I'm not waiting a year. You shouldn't be waiting a year. That's kind of like being at your house and the faucet is leaking and water is pouring out of not leaking, it's pouring out of the faucet, and you call the plumber and he comes, he say, you know what, hey, I'm gonna adjust this, and in about a year it's gonna stop. The water's gonna stop. What do? You get a different plumber. So thank you for coming by. I'm not interested in waiting a year to stop the water. But when it comes to our management of our diabetes, we are willing to wait a year. Actually, we're willing to wait 2 years. People say, well, hey, when I first started 5 years ago, it was 14, and now it's 10. But 5 years ago, it was causing damage. 4 years ago, it was causing damage. 3 years ago, it was causing damage. 2 years ago, it was causing damage. A year ago, it's causing damage. And guess what? Right now, it's still causing damage. And our goal is to decrease, minimize, eliminate the damage that's happening in your body. The problem is that diabetes, and I mentioned this before, the problem is that diabetes doesn't hurt. It doesn't cause it. It's silent for a long time. And so it out of sight, out of mind. Or out of sight, out of mind. So we're like, okay, yeah, I know it's causing something. I'll get to it after a while. I'll get back to it. I'll get in there. I'll do it. I know that I've got to do some stuff. And so that's the thought process that we go through as we're thinking about what we're gonna do in terms of managing diabetes, right? So what's the internal dialogue that your doctor is going through? What's the internal dialogue? All the things that we just talked about, right? What is the first level, right? A1C. What organ is most at risk, right? Walking through the process. What will this patient actually do? What does this patient have access to? What is their capability? What is their ability? If someone is older and they have problems with their hands and they live alone, I will choose a certain set of medications versus others. What's causing this in the first place? Too much glucose coming in? Or is it a liver problem? Or is it a muscle problem? Are they not exercising? Are they not walking? And when will I see them next? Right? So walking through that process. And then as we talk about our patients and what do we need to do for them, if you have not looked at your medications and understood what the medications are doing, obviously there's metformin, which is the one that everybody, I shouldn't say everybody, that's kind of too much of a generalization, that a lot of people, most people, when they're first diagnosed with diabetes, will end up on metformin. Or actually some people who are pre-diabetic end up on metformin because their doctor is using it to delay, prevent, improve their insulin resistance. And then GLP-1 receptor agonist, which is huge in the news right now because it has taken on a life of its own when it comes to the management of weight. And so one of the side effects of the medication, because medication is meant for blood sugar control, but one of the side effects of GLP-1 receptor agonists is that they help with weight. Whole nother conversation. Right, and then the SGLT2s, and you heard me mention earlier that, remember those three pillars? Glucose is coming in, glucose is being created in the body, or glucose is being used in the body. There is a fourth mechanism for how glucose is managed, and that is glucose is excreted. That is, the body takes it, puts it in the urine, and you basically pee it out. And so there's a class of medication called SGLT2 inhibitors, and those medications will, that group of medication will simply take sugar and put it in the urine. And then the DPP-4 inhibitors, these will help your body to decrease the amount of sugar that's coming from your liver and will help your pancreas produce more insulin if it can. So sulfonylureas they make your pancreas produce more insulin, and that's all they do. Now, going back to the DPP-4 inhibitors, now these are what's called glucose-dependent insulin release. So in other words, these medications need to see sugar coming, and once they see sugar coming, then they turn on the insulin. But the sulfonylureas, they don't care. They just go into the body and they turn the faucet on. And so insulin is constantly pouring out. Whether you're eating or not, the insulin is there. That's why they're more prone to hypoglycemia, so low blood sugar, compared to the DPP-4s. And the TZDs, which is a great class of medication, but they've had some side effects in the past. They cause fluid retention. In terms of blood sugar, they do a good job, but the fluid retention can predispose people to heart issues. And so, yeah. And then, of course, there's insulin, and we will do a extensive conversation about insulin coming up and in one of our coming episodes. So we're not going to spend a lot of time talking about that, talking about those right now. So, and let me hop over here really quickly because I want to do, let's do this one. Give me just a second. And so I want to go here. Okay. So the management summary. So what is the goal? Number one, stop the fire. Stop the fire. Stop the house from burning down. We can pretty up the house. We can paint it. We can put new furniture once the house is saved. Once the damage is quieted, then we can figure out some of the other things. Number two, find the driver. What's causing it? Because first we're going to stop it. Whatever's causing it, at that point, we don't care. We just need to stop the fire. Then what's causing it? Now we've identified the things in our bodies, things in our lives that's causing it, and then we build a system to prevent that from causing damage, prevent us from going back in the other direction. Stabilize, identify, and then build. If we do that process, then we are doing the best that we can to provide long, healthy life. So that is a walkthrough on the concept of medication and how medications are chosen. Say bye. We'll be back. All right, so great conversation, and let me hop over here. I do see, and I saw a question down there. Let's go back up. So if you're on medication, I guess let me say this. If you're on medication, I want you to make sure that you understand what the medication is doing. Why did they choose that medication? Was your A1C 14 and they needed to bring that down? If that was the case, you're on more than one medication. And if your A1C is 14 and you are resisting more than one medication, understand what that means. It's not that the one medication can't bring it down, but the length of time that it takes for that to happen, there's damage continually being done. Okay? So I want you to understand what's going on and what's happening. All right, so let's see. I got some questions in there. Let's see, the document of the patient is no longer considered. Okay, so what lab results or clinical criteria must be met for a clinician to decide or determine that a patient no longer has type 2 diabetes? And this is getting at that question of remission, okay? This idea of remission. And so recently, within the last couple of years, the American Diabetic Association has put out criteria, and this is an A1C that is controlled, 6.5 or lower, and the patient is off of medication for 3 months, which is considered remission, and then we have a criteria for chronic remission. And you can go to the American Diabetic Association. You can see those criteria there. Let's see. Saint Zio says, hi, everyone. Hey, thank you for coming through. Thank you for hanging out with us. Thank you for being in this space. Let's see. Steve says, I try to keep my A1C 5.5 or below. It takes a very strict diet to manage that. And Steve, that is a great plan. 5.5. There's a whole. We'll talk more about that. But great. I love that. I love that A1C. And then Jeff says, at what point does an endocrinologist hand over to a PCP? My endo basically fired me when I got my A1C to 5.6 in less than a year on lifestyle change. So interesting conversation, interesting question. Okay. So as an endocrinologist, I want to see everybody. Okay. So that's what I do. I see diabetics. I see people with metabolic disease. I see people with thyroid. I see people with testosterone, and we can go through that list. There aren't enough endocrinologists in the whole world to treat all the people who have all the endocrine diseases. So there are patients who, should they see an endocrinologist? Yes. But do they need to see an endocrinologist? The answer is probably no. Right? And so when a patient meets us, they're say someone is off medication and their A1C is good, then there's really not a compelling reason for them to see an endocrinologist. Now, for all the endocrinologists out there, sorry, I don't mean to take patients out of your practice, right? So the people that need to see an endocrinologist are the people who have the significant issue that need an endocrinologist. If there were enough of us, everybody who has a metabolic disease, everybody who has an endocrine issue should see an endocrinologist. But the majority of the people that are in the world right now who have diabetes do not see an endocrinologist. Why? Because there's not enough space. When I say space, there's not enough endocrinologists to take care of all those patients. And so by virtue of that, most of the people that are being managed are actually being managed by non-endocrinologists. In fact, when I speak, I speak for different physician groups and so forth, the first thing I do is I thank them. I said, thank you for taking care of the patients. Thank you for being out there and doing what you do, because there's not enough of me to go around to manage all of it, and you guys are seeing the bulk of the problems. And for most physicians, honestly, it's not until that patient gets beyond what they think they can manage that they send them to an endocrinologist. But if they think, hey, I can do this, and they are doing it and the patient gets benefit, that patient never sees an endocrinologist, because guess what? It's working. But if it's not working, then, people get sent to an endocrinologist. But different physicians have different criteria, I guess is the answer to the question that was posed. There's not a number that says, hey, when you reach this number, you get to go to a non-endocrinologist. It's like, the endocrinologist has a practice. If you're the guy out in, I don't know, pick a town where there's not any other endocrinologist for hundreds of miles, then guess what? Your criteria for when a patient goes back to their PCP is going to be different from the guy or gal who's sitting in a city where there are 100 endocrinologists. In that case, come on, you just keep bringing them into the practice and you stay there. But if you're the guy or gal out in Podunk somewhere and you're the only person, then the people who get benefit, the people who are improved, the people whose A1C is better, the people who are not on medication, when they reach that point, then they get to go back to their primary care doctor who manages them. And if they have an issue, then they come back to see the endocrinologist, because that allows for the best management of the community. Because remember, our goal is not just that one patient. Our goal is, how do we improve the community? How do we get the community doing better? Okay. Awesome. All right. Well, y'all, that was I love that conversation when we talk about medication and what do we do? How do we go about evaluating patients? And here on this channel, what we do, what I do in all the places where I show up. I'm educating, I'm empowering, and I'm encouraging. I'm educating with the shows, with the blogs, with the podcasts. All the things that you see is with the idea of providing a benefit in terms of thought process, help you to understand how your body works, help you to see things in a different way. Because the more information you have, the more educated you are, then the better decisions you can make. So we educate, we empower, we give you the tools that you need to implement the things that you're learning. Because having the data, having the education doesn't matter if you're not able to translate that into doable things. We educate, we empower, and we encourage. And the encouragement comes from this amazing community that you're a part of. If you want to go somewhere, you can go there by yourself, and you probably can be successful. But if you want to go, you want to be successful over the long haul, go in community. This community is amazing. It allows you to lean on people. It allows you to get support. It allows you to be transparent. It allows you to do some things that you could not do by yourself. And I love this community that we are a part of. If you've not joined our community yet, make sure that you do that. It's an amazing community that we have here in this space. In fact, this week on Thursday is going to be our community meetup. So if you're out there in our accelerator group, on Thursday at 7 p.m., we will have we meet the fourth Thursday of the month, and this week is the fourth Thursday. So pay attention for that link, which will show up in our community board, community voice. It will be there, and then we'll go from there. Okay. All right. So hey, this is this process that we're going through. I want you to begin implementing this in your life on a daily, weekly basis. The goal is long, healthy life. And if we're going to have long, healthy life, then we need to be intentional about what we do. And if you're interested in being intentional about your health, DwainWoodMD.com/brief, BRIEF, or Woode Life Design, WoodeLifeDesign.com, right? If you go there, you could sign up for our weekly health nugget that comes out. It's called the Brief. It's called the Brief for a particular reason, because Brief has the idea that, hey, I'm giving you some summary, some data, and Brief has the idea that it's short, something that's accessible, something that you can do, something that's easily reachable that you can do and implement almost immediately when you get that. Well, I shouldn't say almost. When you get that email, you open it up and boom, there it is. Okay, WoodeLifeDesign.com, DwainWoodMD.com/brief. Hey, we will have our fasting that comes up tomorrow. As we get into this week's fast, we'll have our pop-up right after my meeting with our team tomorrow. So make sure you come out for that. We'll continue going through as we get through this week's 72-hour fast. On Saturday at 9 p.m., we have video from the vault right here, 9 p.m. Central. And then on Sunday morning at 6 a.m. Central, we've got This Week in Review. And then next Monday, we'll be right here, right back here for Dwain Woode MD Live. Hey, this is Dr. Dwain Woode. That's Woode with an E. The E stands for endocrinology. Here I educate, I empower, and I encourage you to take charge of your health and your life. Avoid complications, go to the next level. We're creating the life we've always wanted. I want you to know that you don't need superhuman strength. What you need is a strategy you can trust, a plan you can follow, and you need the support to show up every single time. We'll be right back here next week, next Monday, as we get through, as we get on to Dwain Woode MD Live. Oh, by the way, so I guess let me make a point here. So we have been doing our Wednesday pre-recorded and then doing the show for this season, and we are, y'all, guess what? We're ending this section of the season. And so the new season will be back to our main show on Monday. So the foundations will not be coming out on the week before as we get into just a routine pattern of having our show on Mondays. So pay attention for that. Love seeing you guys here. Love being able to celebrate with you. Have a great one, everybody. Have a good night.